Welcome to Spine Academy. In this chapter, we're going to discuss the clinical evaluation of a patient with cervical spondylosis. So cervical spondylosis, as a reminder, is age-related degeneration of the cervical spine. For those of you who have not reviewed chapters 3 and 4, we talk there about the structural findings of cervical spondylosis, and we talk about the symptoms of cervical spondylosis in much greater detail. So I would encourage you to watch those chapters as well. Here we're going to talk about how you evaluate a patient when you first see them, trying to examine them for cervical spondylosis. So we'll start with an overview of the symptom patterns, and that again is a refresher, if you will, on cervical myelopathy, cervical radiculopathy, and neck pain. And that is the framework that I use when I'm evaluating people with spondylosis. Now, that same framework, I apply it to the clinical history. So we'll talk about the clinical history and how you obtain a good and comprehensive one. We'll talk about the physical examination, and specifically the neurological exam elements that I look for when I'm evaluating people with cervical spondylosis. Then we'll talk about imaging, and not necessarily a comprehensive kind of review of imaging, but how the imaging impacts your decision making and how you use imaging to help diagnose what's going on with people. If you have not seen chapter 2, in which we talk about cervical imaging in greater detail, that may be a very good reference as well to get a more exhaustive evaluation of that. After we talk about imaging, we'll talk about confirmatory studies, which we get sometimes. I can't say we always get them, but they have an important role in diagnosis in some patients. So we'll talk about EMG nerve conduction study and the role that it plays and what it involves. And we'll talk about injections and the relevance of it, not only therapeutically, but also diagnostically. Finally, we'll talk about how you put all this information together. How do you take the history, the exam, the imaging, and maybe the confirmatory studies, and put it together, synthesize it into one understanding of what's going on with the patient. That diagnosis and your confidence in that diagnosis will help tremendously with the decision making for both non-surgical and surgical options that comes thereafter. When evaluating a patient with cervical spondylosis, it's really important to be structured in not only your history taking, but also your physical exam, review of the imaging, and review of any other studies that you might get. So in order to lay an important foundation for that, we'll talk about the structure in which I think about these symptoms. Really, I think of 3 different symptom patterns when I am thinking about and evaluating patients with cervical spondylosis. If you have not seen chapters 3, in which we talk about structural findings or features of cervical spondylosis, or chapter 4, in which we talk about the symptoms, we really get into it in much greater detail in those 2 chapters, and I'd encourage you to watch those. Nevertheless, we'll talk a little bit, I'll lay a little bit of a foundation just for those of you who have not seen those, who just need a little bit of a background on the symptoms of cervical spondylosis. So cervical spondylosis, once again, is age-related degeneration of the cervical spine. This picture shows, for example, some of the things that you can find, like there's arthritis involving the joints in the back. You see a bit of end plate osteophytes, kind of bone spurs and stuff that form up front with degenerative disease in the front. All of that is related to the age-related degeneration. If you take a single slice through the spine, you get an image that might be familiar to some of you guys. It looks like this. Here you can see the disc in the front, and here there's a herniation that's causing some pressure on a nerve on the side here and causing some pressure on the spinal cord as well there. Now, not every patient that has pressure on the spinal cord or pressure on the spinal nerve will have symptoms from it. And again, we're going to talk about the symptoms specifically, not just the structural findings as we discussed in other chapters. Now, just like you can take a slice like this, you can also take a slice down the middle, a so-called sagittal slice, as some of you may know. And if you take a sagittal slice through the spine, right through the middle of it, this is an example of somebody who has a fair amount of disc degeneration with herniations in the front, some ligament thickening that you can see in the back causing pressure on the spinal cord, and you can see fairly significant spinal cord compression over here. You can also see some spinal cord and spinal nerve compression over there. And between these 2 pictures, it really gives you a sense of the types of symptoms that you can encounter. So I like to think of the symptoms really in 3 categories, as I've said before. First and foremost, I think about spinal cord dysfunction, so-called cervical myelopathy. Cervical myelopathy is the symptoms that people get when they have pressure on their spinal cord or dysfunction of their spinal cord. So here, for example, if you have pressure on the spinal cord over here or pressure on the spinal cord, as you can see over here, some of those patients will develop the symptoms of myelopathy, which again are things like clumsiness and difficulty with dexterity, dropping things, balance problems, etc. We'll get into that in some greater detail. The second class of symptoms or pattern of symptoms people can get with cervical spondylosis is cervical radiculopathy. So radiculopathy is a problem where this nerve can be under pressure, and if people have pressure on that nerve there, they can develop symptoms that go wherever that nerve goes. So again, there's a nerve on one side and the other side. People can develop left-sided or right-sided symptoms, and it's wherever that particular nerve goes. People can develop pain, weakness, numbness, and tingling in the distribution of that nerve. It's not like the spinal cord that can affect your whole body. It usually just affects that particular branch. And again, we'll get into that in some greater detail. The last symptom to talk about is neck pain. And again, neck pain is the symptom that I like to put in here because I think about it on every patient I see. It's not easy to say that neck pain is definitely coming from the cervical spine. It can come from muscles, it can come from other things as well. But I like to ask about it just to understand in the event that sometimes it can be attributable to the cervical spine. So the three patterns as I see it would really be cervical myelopathy or spinal cord dysfunction, cervical radiculopathy or nerve dysfunction, and neck pain. And I obtain a history with that framework in mind. I do a physical examination with that framework in mind. I look at imaging, get ancillary studies, EMGs, injections, things like that. But that is always in the back of my mind when I'm evaluating a patient with cervical spondylosis. When I'm evaluating a patient with cervical spondylosis, probably the single most important element is getting a good clinical history. And that's true in a lot of domains, but certainly true in spine surgery. So when I get the history, I often will find out about what bothers them the most. But immediately when I'm talking to a patient, I really try to remain structured about the symptom evaluation itself. So the first thing that I like to ask about is symptoms of cervical myelopathy. So again, cervical myelopathy is problems related to spinal cord dysfunction. And the symptoms that people get really can involve the arms and the legs. So the first thing I ask about is distribution of those symptoms. So I will ask people about in the arms if they have difficulty with dexterity. Have they been dropping things more? Having difficulty with buttoning their shirt, zippers, jewelry, things like that. Myelopathy of the upper extremity, which is frequently involved when it's spinal cord compression in the neck, will typically cause symptoms like that. It will cause problems with clumsiness, dropping things like that. Now, it can also affect the lower extremities, as we talked about in the chapter on symptoms. In the lower extremities, people really have problems with gait, balance, so they feel unsteady, they feel like they're drunk when they're walking. So the first thing I ask about will really be the distribution, the presence of these symptoms. Do they have involvement in the arms, involvement in the legs, etc. Then we talk a little bit about whether they have any subjective weakness, which can come from spinal cord dysfunction. We'll talk about allodynia, which, as some of you may know if you've seen another chapter, really is hypersensitivity. People, even just brushing them can be very painful. And we'll talk about a Lhermitte's phenomenon. So that is when people can change their neck position, classically move their head forward or move it back, and feel like a jerk, like a lightning bolt that goes through their body. We call that a Lhermitte's phenomenon, and it's often attributable to spinal cord compression and spinal cord dysfunction. We also will talk about the timing of these symptoms. So you want to figure out how long have these symptoms been present, how quickly have they been progressing? Because if it's rapidly progressive, it changes the management and the kind of timing of how quickly you want to manage these patients. And then finally, I like to talk to patients about how much these symptoms are affecting their quality of life. Sometimes you'll see patients where it's like even a little bit of it can be very disruptive to their quality of life because maybe their job depends on dexterity. Other people may have a little bit of balance dysfunction, a little bit of clumsiness, but not enough to affect them. And that will have an influence also in decision-making afterwards about how to manage it. So the first set of symptoms that I ask about relate to cervical myelopathy. Then I will often change gears and I'll ask about cervical radiculopathy. And those are symptoms that often affect the arm. So as we've spoken about before, cervical radiculopathy typically causes symptoms that radiate into the arm when it's in the cervical spine. We'll talk about the distribution specifically. So if people are having pain, numbness, tingling, or weakness, where does it go? Is it down the back of the arm, the side, down to the thumb? Which fingers does it involve? Things like that. So we call that distribution. So I will ask about distribution of symptoms, and it can be right-sided, left-sided, or both. It can be into specific nerve roots, and I try to be clear about that. So as people are describing their symptoms, in my own mind, I try to say, that sounds like a C5, or that sounds like a C7 radiculopathy, and try in your own mind to try to be structured about it, understanding that not every nerve reads the book. Then we'll talk a little bit about the character of those symptoms, because people can have sharp shooting, lightning bolt type pain that's very kind of stabbing, or they can also have like burning, chronic, toothache type pain. And the type of symptoms that they have can have implications on whether that nerve irritation or nerve dysfunction is active or acute or recent, or has been going on for a really long time, which can also have implications on types of treatment that are available to them, types of medications that can work for that. Then we will talk about aggravating and ameliorating factors. So are there specific positions that can make people better? Are there specific activities or maneuvers or things like that that can either make people better or make them worse? And that can lend some insight into whether it's truly coming from the cervical spine. Again, we'll talk about timing, so we talk about the onset of it and how it's evolved. Did it start out really bad and has been slowly getting better, in which case maybe we just wait and give it some time? Has it been kind of building up and getting worse? Do people have a period where it's like really awful and then gets better and then really bad again, and every time they do even a little bit of activity, the symptoms come back on again? That timing or cadence can have an implication as well in decision making around how to manage it. And then also quality of life, like how much does it affect people? And I've had patients who are, say, carpenters and have to swing a hammer, and a bit of tricep weakness is a big deal. I can have people who are otherwise affected, people that drive or really are dependent on specific functions. A C7 radiculopathy, for example, can affect people differently if it's in the right arm or the left arm, or depending on what their occupation or hobbies are. And understanding how much it is affecting people's quality of life is really important in meaningful decision making. So the second category of symptoms that I ask about in a very structured way is cervical radiculopathy. The last set of symptoms that I ask about really relate to neck pain. And as I think I've said a number of times in prior chapters, neck pain is one of these very ambiguous things. We cannot say for sure that neck pain is coming from cervical spine. We certainly don't operate for neck pain alone. Certainly I'll see patients who have neck pain who may be undergoing surgery for something else and will see relief of their neck pain, but it is very hard to tell where people's neck pain is coming from. Nevertheless, I do ask about it. So we'll ask about what part of the neck. Is it over here? Is it coming down here? What does the neck mean? Some people will say scapular pain is neck pain. It could be going into the head. The back of the head can be neck pain. So really understanding where that symptom is, I think, is important. Trying to figure out if it's coming from a nerve in your mind. Is it radicular? Or is it muscular or coming from something else? Looking at the character of the symptoms can help a bit with that. We look at aggravating and ameliorating factors. So is it specific types of activities or maneuvers or manipulation, or maybe they see a chiropractor gets better or gets worse, traction, different types of things that can maybe make the neck pain better, that can really ideally lend insight into where it might be coming from. Also talk about the timing. How has it evolved over time? When did it start? And all of those things go together into figuring out or characterizing at least the pain that people can have in their neck, which again may or may not be coming from the cervical spine or be part of it. So once I have done that, like once I've talked to them about symptoms of myelopathy, radiculopathy, and neck pain, and I may talk to them about it in different orders depending on what bothers them the most, but I'll always ask about all three of those, and then I try to put together a structured summary of people's symptoms. So we'll talk about cervical myelopathy, how severe is it, how rapidly progressive is it. We'll talk about cervical radiculopathy, what nerves are involved, what side is it, is there weakness involved, which can also sometimes affect how quickly you want to intervene. And again, I'll qualify all these by saying how much it's affecting them in terms of quality of life. And then neck pain. And this is often what you'll see if you look at one of my notes. It will say, this is a 46-year-old with 70% right arm pain and 30% neck pain who presents with X, Y, and Z. Kind of characterize it in that way, but think about it in a very structured way, looking at these three different symptom patterns, myelopathy, radiculopathy, and neck pain, and putting it all together into one structured summary of what they present with. Once you have that, part of the history taking is also understanding what kind of treatments they've undergone. So if you're a spine surgeon like me and you're seeing a patient, often they've had a number of different physicians see them in the past. Maybe they're a primary care doctor, chiropractors, acupuncture. Maybe they have a therapist of different sorts or physiatrists or people that are seeing them. So characterizing that can help as well. And it's not just to chronicle what they've had done, but it's also to understand how they might have responded. And that can lend a bit of insight into where their symptoms are coming from. So I will talk a lot about the types of treatment, so physical therapy, types of injections, chiropractor, acupuncture, yoga, Pilates, aquatherapy, other types of interventions they might have undergone. Then I'll also ask them about what kind of relief they got or response they got to those different treatments. And that can involve a little bit of detective work. If they say, oh, injections gave me a lot of relief, you want to figure out where those injections were done. And I don't mean geographically, I mean like what part of the neck was that done in? So you can really understand, all right, well that may be where the symptoms are coming from. Then I will ask them about prior surgery, because that can have important implications. If they've had a prior cervical fusion, for example, or have had multiple other surgeries in the past, that can have an impact on what you're looking for. Because a lot of this part of it is still the detective work of trying to figure out where somebody's symptoms are coming from. So trying to understand it in an organized way and then figure out where it's coming from. Types of prior surgery can have an impact on that decision-making and the diagnostics. We will ask a little bit about how they responded to those prior treatments as well. All that goes into talking about the prior treatment. There are some other things that are particularly relevant when we're evaluating patients for the spine. And so I'm a dedicated complex spine surgeon, a neurosurgeon. So, they say if all you have is a hammer, everything looks like a nail. It's important to take a step back and think, people can have shoulder problems, they can have other arm problems, they can have peripheral nerve problems, carpal tunnel syndrome, ulnar neuropathy. Some of these things are things that can masquerade as cervical radiculopathy, like thoracic outlet syndrome. We have to kind of keep a broader perspective so that you don't call everything cervical radiculopathy and make the mistake of jumping into surgery when something is actually coming from somewhere else. So I'll ask about other relevant history. Have you ever had a shoulder problem? Have you ever had surgery in your arms before? Ask about peripheral nerve problems if they've ever been evaluated. Ask about symptoms that might be more attributable to peripheral nerve problems. So does it wake you up at night? Do you find yourself shaking it to get rid of it? Things like that can point more to peripheral nerve problems. Do they have other neurological conditions that could affect them, like whether it's a neuromuscular problems, movement disorder problems, things like that we don't kind of outside the scope of this conversation, but we will ask about different neurological problems that can also kind of color the picture of what you're seeing. Rheumatologic conditions very commonly can be encountered, and that's a whole variety of rheumatologic conditions that can affect how the different types of symptoms that people can develop. And then contributors to gait dysfunction. And as people get older, there are 100 reasons for them to have problems with the gait. So not all gait dysfunction is myelopathy. There are, again, like myelopathy, one of the classic tests for it is tandem gait. You have 2 beers, your tandem gait is going to be off. So a lot of things can affect the gait. It's not only the cervical spine. We're looking for patterns, as I've said again and again. But you ask about other relevant history to kind of figure out if there are other contributors to some of these symptoms that you're seeing or these complaints that you're seeing. And then finally, of course, other medical and surgical problems that may affect their neurological condition. All of that goes into good history taking for the cervical spine. It lays the foundation for a meaningful physical exam, any ancillary tests, and an intelligent review of the imaging where we really kind of pay attention to try to put together a full composite understanding of what a patient's symptoms are, where they may be coming from, and to develop a really powerful and meaningful management plan that may or may not involve surgery. So after getting a good history, obviously a big part of the evaluation is doing a good physical examination. And of course, I mean neurological examination for a lot of this, but we'll talk primarily about the full neurological examination when we're doing an evaluation for a patient with cervical spondylosis. The first thing we look at is a motor exam. So obviously the exam itself is made up of multiple components, but the motor exam is the first component we're going to talk about. I will do typically a sensory exam after that, a reflex examination, which is particularly important in spine evaluation, gait evaluation, which is variably important. Sometimes it's more important if somebody's not myelopathic, you may not assess that as deeply. We talk a little bit about the neck, looking at cervical range of motion, palpation exam of the neck. Those are a bit more general. And then I look for a couple of very important things in select patients. I will look for a Sperling's maneuver that we'll talk a little bit about later, do somewhat of a peripheral nerve exam, and then talk a little bit about the shoulder exam. And I'm not going to get into the shoulder exam in this video because you can obviously find a variety of resources for that, and this is kind of outside of the scope of this. But I would say it's important for a spine surgeon to know how to do a good shoulder exam when evaluating a patient in the neck, or a hip and knee exam when evaluating somebody for the lumbar spine. So these are the components that I typically look at. First thing we'll talk about is a motor exam. And again, when we do a motor exam, we're looking not only at strength, so we'll evaluate a patient's strength in specific motor groups, but also looking at the tone and the bulk, which can lend some insight into other neurological conditions that may be contributing to the symptoms. I will do a deltoid exam, so that's a shoulder exam, which is classically a C5 distribution. Now, a lot of these muscle groups, as you'll see, can get nerve function or innervation from different nerves. So unfortunately, not every muscle, not every nerve has read the book, but these are kind of the classical distributions that we talk about and think about when we're evaluating patients. So deltoid exam is the first thing I do, and that's to evaluate for C5 function. I will do a bicep exam, which is typically C5 and C6. I do typically pronator teres, which is a little more sensitive for C6. Sometimes you're not really sure if it's 5, 6, or 7. I find the pronator teres exam to be very useful for that. So there's holding someone's hand like you're shaking it and then twisting outwards. Pronation tends to be pretty dominant C6, I would say. I look at wrist extension, which is classically C6 as well, with some C7 contribution from the radial nerve. Talk about wrist flexion. Triceps, which is another big muscle group, which is often C7. So if you're looking for a C6, I tend to favor the pronator teres. That's personal. Triceps, I tend to favor a tricep extension or elbow extension. I will look at wrist flexion as well when I'm doing that. And then for C8 and T1, I tend to use finger extension, so kind of evaluating people for extension of their fingers, especially distally. And then finger abduction, to kind of doing this to test for T1. And that gives you some rough sense of what muscle groups are affected when you're looking at cervical radiculopathy, especially from C5 down to T1. So from a motor exam standpoint, these are the motor groups that I typically will evaluate. The lower extremity I will always evaluate as well, but maybe a little bit more cursory, not necessarily looking at every muscle group as if I'm doing a lumbar spine evaluation, but I look at iliopsoas, quadricep, hamstring, and then ankle, dorsiflexion, and plantar flexion. And the reason I kind of put this in here is because one interesting little factoid is people with myelopathy, preferentially what they'll notice when they have weakness in their legs is usually proximal leg weakness, so difficulty going up steps, getting out of a chair, things like that, where they have difficulty with some of the big muscle groups up high, and dorsiflexion, so a foot drop. People will find that they're either slapping their foot or having difficulty picking their foot up, catching their toes. You think of L5 radiculopathy or L2, 3, 4, et cetera for IP, but those can be motor deficits as a manifestation of myelopathy, either in the cervical or the thoracic spine. So I put it in there specifically because I look for it even in people that I'm doing a cervical evaluation for. Now, in terms of sensory dysfunction, that's usually the next part that I look at. And I will typically look at light touch, sometimes pinprick and vibration. Again, if you haven't seen a chapter on symptoms of myelopathy or symptoms of spondylosis, I'd really recommend doing it. But this is one of the pictures that we show there, and you can kind of see that the nerves have dermatomes. We'll look at dermatomal distribution in terms of loss of sensation. And you're really trying to characterize, like, is that a C6 distribution, a C7 distribution, to kind of lend insight into which nerves are affected. So I look at these different modalities and try to figure out, is it nerve root distribution? Is it peripheral nerve distribution? Or do they have a sensory level which can be more indicative of spinal cord dysfunction? Now, one interesting little factoid is that the more distal you get along the nervous system, so that means from the brain through the spinal cord, cervical nerve, down as you get peripheral all the way to the fingertips, the more distal you get, the more crisp the sensory demarcation is. So that's an important thing I learned from Dr. Spinner at Mayo, is that when people can draw a line on their finger and say this side of it is numb and this side of it is not, when it's that sharp, it's usually peripheral. A C7 radiculopathy can be a little bit more vague. It's still more defined than if people have something in their brain, where it might just be, if it's brain, it's just like my arm is numb. But when it's C7, it'll be like, well, this part of it is numb, but it might be a little more ambiguous here. It might be middle finger, part of the ring finger, part of the index finger is affected, or for C6, it could just be the thumb, maybe it bleeds over to C7. But again, the demarcation, the limits around them are a little more ambiguous as you go centrally, or a little more crisp as you go distally. So that's an important point I wanted to make in terms of trying to use the sensory exam to figure out where people's symptoms are coming from. Now, after doing a motor and sensory exam, we routinely get reflexes. So reflexes are really interesting. We try to create a stimulus and see the reaction to that. So this is a good example of a picture that kind of shows like an afferent stimulus. That means like, you know, whether you get poked or you get hit with a hammer or something like that, you get an afferent stimulation, and then you get a reaction that comes around through the motor fiber. So if you hit somebody's knee classically and it jumps, that's what we're looking for as a reflex arc. Now, this is a useful illustration because it shows that there is input from the brain that comes down to mediate that reflex. The reason that's important is because if there's a problem along the arc here, you won't get a reflex. You'll hit someone's knee, you won't get anything back. That's classically related to a nerve problem. In the arm, if you check a bicep or a tricep and you hit it and the reflex is absent, it means there's a problem typically here, somewhere along the way there. But if it's missing function from the brain or the influence of the brain, that reflex tends to be exaggerated. So you'll hit someone's bicep and it really jumps because you don't have the so-called inhibitory effect of some of these descending pathways from the brain. So when we are evaluating someone's reflexes, we're trying to figure out, is it normal, is it diminished, or is it increased? And those extremes are really important in the decision-making or the analysis of where people's symptoms are coming from. So in terms of the types of reflexes that I check, I usually check them all. The pectoralis reflex I'll check on rare occasions. It's not often that you're looking for a C3-4 radiculopathy. Biceps, brachioradialis, and triceps are routine. Every time you're evaluating someone for that, you're going to look for that. I will often do a finger flexor reflex as well. And then looking at the lower extremities can be useful, particularly for spinal cord dysfunction. So looking at not only the knee and also the ankle to kind of see how those reflexes are affected. That gives you a sense of, are we dealing with contribution from the brain? Is this a spinal cord problem? Is it a peripheral nerve problem? Is it a diffuse problem? If every reflex is absent, that gives you a sense there's a problem with the peripheral nerves in general. So this is why I think reflexes are such an important part of a good neurological exam. Now, from the spine perspective, there are specific pathologic reflexes that you may see if you're a patient, or if you're a clinician, certainly you should look for. In the upper extremities, a Hoffman's sign, which is usually flicking of the middle finger and looking for a little jump or a contraction of the thumb and the index finger. That's called a Hoffman's sign. A Babinski sign is a stroking of the bottom of the foot and seeing your toes kind of fan upwards. And then clonus is when you, and really you could see it at any joint, but classically at the ankle is when there's abrupt stretching of a muscle that you get kind of people with spasticity, or a loss of that inhibition will often have flapping that will go on more than 4 beats. We call that clonus, when they have sustained kind of flapping like that. So these are considered part of the reflex examination and part of what we're looking for when we're doing the full physical exam. Now, the gait is often overlooked, but whenever I evaluate a patient, I try to get them to walk, and sometimes in just the clinic room may not be sufficient. You have to get them into the hallway to really see what they're doing. And it's routine for people to serve their families to say, oh, they're walking much better here than they do at home. And that, you have to take that into consideration when you're evaluating people in the office, is that they're kind of on their best behavior, kind of putting their best foot forward. But you look at stride length and speed, you look at width, symmetry, antalgia. Antalgia is like limping, classically not a neurological thing, but if people are like not able to put weight on a foot, it means it's usually not coming from the neck, but they may complain of balance dysfunction. Just like if you sprained your ankle and you're not walking right, your balance can be off, but it has nothing to do with your nerves or your spinal cord. So looking at that gait can give you a sense of where the symptoms may be coming from. We always ask about tandem gait. So tandem gait is like putting one foot in front of the other, like you're doing a sobriety test. That's an important test to kind of look at all the conduction. It takes a fair amount to be going right for you to be doing a good job with tandem gait, but a lot of things can throw that off. And so it doesn't necessarily mean that you have a spinal cord problem, but we look at it every time. And then a Romberg is a test that looks at balance with the eyes closed, and that can be useful just to understand how well are the signals getting from your legs up to your brain and back down again. Kind of useful. I wouldn't say it's central. You can't hang your hat on that alone, but I think it's a part of the exam. It certainly goes into the gait evaluation as well. Now, when you're looking at people with cervical radiculopathy, for example, I think a very, very useful test is something called a Sperling's maneuver. So a Sperling's maneuver, if you think about it, when people have compression of a nerve, you do a maneuver that kind of compresses the nerve even further and see if it recreates the symptoms into the arm. Not just do they have pain, but so classically you'll turn your head, lean it back, compress down, axially load them, compress the nerve, and see if it reproduces the symptoms into the arm. That is classically called a Sperling's maneuver, and it really, what it says to you is that symptoms are probably coming from the cervical spine. That's really what you're trying to make sure is it's not like a shoulder problem or an elbow problem or a carpal tunnel or some other thing. If you can go like this and kind of recreate the symptoms into the arm, it often means it's coming from the cervical spine. So Sperling's maneuver, I think, is really important. As I had alluded to at the beginning of this section, I check for cervical range of motion, neck palpation, peripheral nerve exam, and a shoulder exam, and all that is part of the exam, but a little bit outside of the scope of what we're going to talk about here. The idea of doing all these tests is to try to understand if the physical findings that they have on your exam are concordant with the theories you have about where their symptoms are coming from, to kind of make sure their symptoms and their exam match up. So to this point in our discussion of clinical evaluation, we've talked about obtaining a good history and performing a good physical exam. So by the end of that, what you really want to have accomplished is have some sense of what types of symptoms your patient has and whether there's any kind of physical exam findings that support that. Now, once you have done that and you have a sense of like this person sounds like they have a C6 radiculopathy, they have mild myelopathy, etc. Once you've done that, it's time to get into the imaging. And I usually won't go into a room having evaluated the imaging first, but rather evaluate the imaging once I have a sense of what's happening with the patient. So Chapter 2 really discusses cervical spine imaging in much greater detail if you're unfamiliar with it, and I'd encourage you to watch that if any of this seems unfamiliar. But we'll bring up an image here of a cervical spine MRI. This is a T2 sagittal image, and you can see here how this is really good for looking at the discs, it's good for looking at the spinal cord over here. On some sequences you can see the nerves very well. You can see the fluid around the spinal cord, this white stuff over here. You can see it kind of all the way down here and its absence over here. You can also see a little bit of swelling within the spinal cord over there. All of that is what an MRI is really good for. Good for looking at soft tissue, good for looking at fluid, so that's good for the spinal cord, the discs, things like that. If you had to look at only one study, it would be the MRI scan. But a question that people often ask me when they come in with an MRI is, well, why do I have to get a CAT scan if I have an MRI? And a CAT scan is a study that looks at the bones. So for example, this sequence here, you can kind of see the vertebral bodies themselves. This person has a lot of arthritic disease at multiple levels. There's a little bit of a step off right here, maybe a little bit of a step off at these other levels. They have a bit of kyphosis, which is that leaning forward that we spoke about in Chapter 3. All of that is stuff you can evaluate incredibly well with the CAT scan. You can look for fractures, other bony abnormalities, but you really can't see the spinal cord at all. So you can see the bones very well. The MRI, you can see everything really well except the bones. So between the MRI and the CAT scan, you can have a fairly comprehensive view of what's going on with the cervical spine. Both of these studies are done, though, MRI and CT, with people lying flat as a general rule. So I often get, as a last study, routinely dynamic x-rays. So those are films done leaning forward and leaning back, and here you can kind of see, it gives you a sense of what people's range of motion is, gives you a sense of what they look like when they're actually load-bearing, when they're standing up, helps you see if there's any instability, what their global alignment is like, etc. So those are the three studies that I get routinely when I'm evaluating people from a surgical perspective with cervical spondylosis. Now, when you look at those, really the priorities are a couple. Of course, it's useful to kind of go through everything. So just understanding the structural condition of the cervical spine is valuable, and that's great. But what you're really trying to do as a clinician is you're trying to correlate the symptoms and the exam findings with structural findings on the imaging. So if somebody who comes in with, say, symptoms where you're pretty convinced they have a C6 radiculopathy, you're going to look at the C5-6 foramen and see how the nerve looks, make sure it makes sense. If they have right-sided symptoms, they need to have right-sided pathology, etc. And try to correlate those so that their exam and their history correlates with the imaging. That's very important in trying to identify causation, or to be able to say, like, yeah, that structural problem is causing this person's symptoms. So when I do look at the imaging, although I look at everything, I really am paying particular attention to making sense of the imaging relative to the symptoms and the physical exam that I have obtained already. So now we've spoken about getting a good history, doing a good physical examination, and reviewing imaging. And in my experience, that pretty much pertains to every single patient that I see that I'm evaluating, whether it's for neck or some other part of their spine. These studies that we talk about next are studies that we don't get 100% of the time, but I broach it specifically to talk about what these studies are in case you or someone has had them, or if you're thinking about ordering them if you're a clinician. And also talk about the role that they can play in helping you on some occasions really help make a diagnosis. So if we take a step before this and really think like, where are we now? We've gotten a good history, we've done a good physical examination, and we've looked at their imaging. The goal first is to synthesize that information. So we want to organize the symptoms into symptom patterns. So again, talk myelopathy, radiculopathy, neck pain, kind of think in a structured way so that you can kind of understand what you're looking for and what you're trying to treat. Then you look for concordance with the physical exam, as we said earlier. So somebody who has, let's say, a C6 radiculopathy, you're looking for specific patterns of weakness, maybe specific patterns of numbness, reflex changes, things like that, to see if those fit together. And that helps if they fit, and it makes it confusing if it doesn't, obviously. Then you want to correlate their symptoms and their physical exam findings with what you see on the imaging. So the MRI, the CT, and the x-rays, I get them routinely or more or less routinely, but you're trying to correlate them to identify structural causes for the symptoms and physical exam findings that you have. And then often those things don't all line up. Like sometimes you'll say, boy, they sound like they have a C6 radiculopathy, but they have a pretty big C6-7 disc herniation, or vice versa. Or they have some other structural. I can't find anything on their imaging to explain the symptoms they have, but they have exam findings and symptoms. Things don't always line up. Not every nerve, not every disc has read the book. And so trying to be organized can help you figure out what problem you're trying to solve. And frequently in those situations where you're not 100% sure, you're like, could it be a C5 radiculopathy, or do they have a shoulder problem because they were involved in a car accident and all the symptoms started afterwards? And of course, people that are injured can have more than one thing injured at the same time, especially when they're close together. So when you're in a situation like that where you're trying to figure out, is this really coming from the cervical spine, there are a couple of things that I get routinely in those situations. One of them is I get cervical injections. Now, I may get cervical injections anyway in an effort to try to treat people conservatively, but the role of injections goes beyond just treatment. It can have important diagnostic value. I will frequently see patients who think, well, I don't want injections, that's just a Band-Aid, or I did injections and it gave me relief for like a couple days and I don't want to try them again because it wasn't worth the effort. And I get that. But at the same time, I think it's important to underscore that injections have not only therapeutic value, or maybe not in their case, but certainly can have diagnostic value as well. So a response to injections can be very valuable, and we'll talk more about it in some detail, but really think about if somebody gets an injection to their cervical spine and all that pain in their arm goes away, even for just a couple of days, if nothing else, it at least says it's coming from the cervical spine. And then the second study that I often will get in those situations is an EMG nerve conduction study. So that is electromyography and nerve conduction study, which you often have to send to a specialist to do. And that is a test that looks at nerve function. It can help lend some insight into, are we dealing with the nerve? Where is the problem with the nerve? Is it musculoskeletal, et cetera? Try to lend some insight into where people's symptoms are coming from and how to make sense of them. So the first thing to talk about is going to be injections. There's a lot of different types of cervical injections, and that's kind of outside the scope of this, not only from a time standpoint, but also since I don't do injections. Usually it's performed by a specially trained physician, but the types of injections that are done are epidural injections, sometimes selective nerve root injections, although those are a little bit controversial and inconsistent. Not everybody does those. And of course, facet injections as well. Those are injections that target the spine. There are other types of follow-up injections you may have heard of, radiofrequency ablation or rhizotomies, trigger point injections, et cetera. But these are the kind of most common that are useful from a diagnostic standpoint in my perspective. Usually these injections are done by specialists that really train in this. So these are different types of, whether it's a physiatrist, which is a physical medicine and rehabilitation doctor, often they're specially trained in fellowships for spine care. or anesthesia pain management. These are anesthesiologists that usually do a year or two of extra training afterwards to do some of these interventions as well. Some neurologists will do the same, but these injections are typically performed by specialists. And if you're a patient who is seeing a spine surgeon, they often will send you to somebody they may have a good relationship or trust to do these injections. And of course, if you're a clinician taking care of them, it's important to develop good relationships with honest, capable people who can do these injections in trying to figure out what's going on with your patients. So when we ask people to get injections, it's important to know what they did. So I often will get the procedure. It's important to know what was targeted. It doesn't always have to be selective. If somebody gets a cervical epidural injections and their symptoms go away, at least you know it's cervical. If you're trying to figure out if it's C6 versus C7, that can sometimes be a little bit more difficult for injections to resolve because the liquid that they put in can kind of bleed over into other areas. It can kind of leak into other areas. You can't like hang your hat on the fact that they said they did a C7 and it must only be at C7. So selective injections are nice, but they're not essential. But regardless, you have to know what type of injection they did to be able to make inference about where the symptoms are coming from and know where the injection was given, like what part, what level it was done, and where the contrast may have gone and where the steroid may have gone. It's also important to know the extent of relief. I can't tell you how often people come in and say, I had injections that didn't do anything for me, but then you talk to them about it and it can mean a lot of things. Some patients, yeah, they got a lot of relief, but it lasted 3 days, and in their mind that like wasn't worth the trouble. But the fact that they got a lot of relief can be very valuable. From a diagnostic perspective, can be very valuable. Sometimes people say like, yeah, I mean, it helped me for a few weeks, but it was just a little bit. And those are all different answers. So understanding how complete was the relief, was it a lot of relief, a little bit of relief? Did they get no relief at all? Not even transient. If you ask them, I got an injection, it didn't even change a thing. I didn't feel better, even on the drive home, I didn't feel better, never got better along the way. That also has different implications, right? That seems to favor like, maybe it's not coming from the cervical spine. Then how long did the relief last? And it's not uncommon for people to think, oh, that doctor did a bad job because the injection didn't help me. But if it's coming from a shoulder, an injection in the neck isn't going to help. I often will ask people to get a second injection just to be sure. I don't know that I could really hang a full diagnosis off of one injection that didn't work. But if somebody gets 2 cervical injections and it didn't give them even transient relief, not even a little bit of relief, you can almost use that diagnostically to say like, it may not be coming from the cervical spine. I get much more cautious about some type of surgical intervention if they got not even transient relief from cervical injections for things like cervical radiculopathy. Now they may not help with neck pain, they may or may not. They certainly, I don't use them for myelopathy, but there's a very important role for cervical radiculopathy in looking at cervical injections. The second study that I get, which is a confirmatory study, so again, I don't get it in everybody, is an EMG nerve conduction study. And you'll see this acronym here, EMG/NCS, which stands for electromyography and nerve conduction study. So most people have heard of an EKG. This is where you're looking at heart function. This is looking at muscle function. It's done the same way. It's a test that's designed to look at nerve function. And it will look a little bit at muscle function as well for people that have other neuromuscular problems. It's usually performed in the office. It's usually done by a neurologist or a physiatrist. There are some primary care doctors that are kind of trained in it or have a box that will do it or have a tech that does it, but I tend to preferentially send people to real experts on it, people that do a lot of it. Because it's important in the interpretation of it to have a lot of experience. So generally it's neurologists and physiatrists. And if you're a patient, often your spine surgeon may send you to somebody specifically to get that done. And of course, if you're a clinician, it's important to kind of develop a relationship with real specialists that you can count on doing a good quality EMG, because they're not all the same, just like many things in life. Now, this procedure involves testing muscle behavior, and it tests it with needles. It also looks at nerve conduction, so there's 2 different dimensions to this. So for example, the technician will put needles into the muscle to see how the muscles react. And that recording is a big part of the electromyography. And then they also will test conduction. So generate a stimulus, how long does it take to get here, how long does it take to get there? And there are certain kind of thresholds for what's a normal velocity for a nerve. And if that's diminished, it may indicate that there's a problem with the nerve conduction, and there's a variety of different types, but that is why an EMG nerve conduction study can be valuable. Now, if you've gone and had one of these done, you get some report that looks completely inscrutable. You look at it, it basically shows you all these muscles that put needles into and how they behaved. Now, to a clinician, when I look at this, I care about how many muscles do they put it in, every muscle they put it in, they can make a comment on. If you get one of these and you have like 3 muscles in there and not a very detailed exam, it's hard to make meaningful inferences on that. Whatever the impression says at the end, how accurate it is has a lot to do with the resolution of it. And so we want to see that they've really tested some relevant things. So one of the things you'll see here is the right C7 paraspinal muscles. That helps you verify that it's truly coming from the cervical spine. And it's not important to kind of get into what this data actually says or what these waveforms mean, but when looking at this raw data, you want to know what muscles were tested. And roughly, when I'm looking at these, I kind of look at, is it on this side, are there abnormalities, or is it on this side of it? And I draw a line kind of right down the middle here vertically. And these early features that you see are typically signs of active irritation, and the farther ones are chronic. And I'll get into that in just a minute. But this is what the output looks like from an EMG nerve conduction study. So when you go to a technician or you go to an office, the technician does this procedure, a clinician will interpret all that information. What they are looking for is patterns of abnormality. And for example, they may see certain muscles involved and say, gosh, these muscles involved, that must mean that they have a C6 nerve problem, because that's the only way that those muscles intersect, or C7 distribution, or they have some other type of peripheral nerve process. But if you really take a step back, what the clinician has is raw data, and they're making an inference about where that must be coming from. So I often will take that out of it as subjective as well and say, well, what raw data do we really have? Because yes, in general, C7 may go here, but maybe this nerve didn't quite read the book, or that muscle didn't quite test out exactly right. None of these tests are perfect, so I like to look at the raw data, but the raw data has implications in looking at patterns of abnormality. It helps us figure out chronic versus active. And I won't get into that a whole lot, except to say that when somebody has acute irritation of a nerve, we call that active or acute radiculopathy, sharp shooting pain that goes down their arm, numbness, tingling, sometimes weakness. When it's chronic, think that that has been there. That may be nerve damage that has been there for a long time. The features of it are different. It's often burning, toothache type pain, hypersensitive. There are a lot of different symptoms, very different from the sharp shooting lightning bolt going down the arm type of a pain. That may be more indicative of chronic radiculopathy. And the reason that's important is chronic radiculopathy may or may not get better if you take the pressure off. In other words, if there's old damage and the damage is done, surgery may not help it. We sometimes still do them for other reasons and stuff, but as a general rule, chronic radiculopathy may or may not respond well to surgery. And so knowing that will help with the decision making. We're looking for cervical versus peripheral problems, and this can help as well with the EMG. So is it a problem truly coming from the neck, or is it coming from further down? And there's a few different features that we look at to help make that distinction. But one thing I will say is that it's important that the technician put needles typically into the muscles of the neck. There can be a little bit of gray area with it, but it's useful to try, and I think can have valuable implications in figuring out where symptoms are coming from, whether it's the neck or the peripheral nerves. Which nerves are affected is obviously how people use it. Now, I don't, again, hang a hat on the idea if somebody says in the impression this is C7 radiculopathy, if it doesn't fit with the symptoms and doesn't fit with the imaging, I may not say 100% that's what it is, but it does help us figure out what muscles are involved. That's very accurate. Muscles don't lie when they put a needle into it. And so I will try to use that to make sense of where people's symptoms are coming from. And then it helps us look for more diffuse neurological or neuromuscular or musculoskeletal problems as well. People can have other types of, like ALS or other conditions that can affect it, peripheral neuropathy that can affect things as well. And all of that is useful information that comes from the EMG nerve conduction study. So the value of getting these confirmatory studies, injections, sometimes they can be therapeutic, but often diagnostic, an EMG nerve conduction study is to help establish or validate a diagnosis. So when you evaluate a patient, you want to have a sense of like, what is their diagnosis? Where are their symptoms coming from? And it may be from more than one thing. It helps you assess the reversibility of the symptoms. And as an example, if somebody gets an injection in the setting of radiculopathy and their symptoms get better, but not for very long, at least you know if you cool that nerve off, it should get better. And surgery usually is a little bit more favorable in that situation. It helps to look for alternate contributors because there may be more than one thing going on. Do they have a peripheral nerve problem? Do they have a shoulder problem? Some other systemic neurological condition that may be superimposed on it? Because that will help inform not only how you manage it, but also help figure out like how likely are people to get better, so you can give them realistic expectations for how they should do afterwards if they do end up undergoing some type of surgical treatment. We use those studies not systematically, but frequently enough. What's important by this point is that you feel that you have a very clear sense, or as clear as can be, sense of where people's symptoms are coming from, and that will inform, importantly, how they get managed. So in the evaluation of a patient with cervical spondylosis, there are many elements as we have reviewed so far in this chapter. The history, the physical examination, review of imaging, and review of sometimes confirmatory studies, those all go into trying to come up with a diagnosis for a patient. So a diagnosis sometimes feels like a conjecture. You're saying like, listen, I think you've got these symptoms. I think they're coming from this finding on the MRI. We got injections. It seems like it gave you relief. The more stuff you can line up, the more confident you can be in your diagnosis. And I think the more effective you can be in your treatment, whether it's surgical or non-surgical. Now, for surgery to work in the spine, I believe that there are really 4 important, seemingly redundant, but important rules. And these are rules that I use. This is not dogma by any means. But the rules that I use are the following, and they seem pretty commonsensical. Number 1, patients have to have symptoms coming from their spine or the spinal nerves or the spinal cord. Think about this. So for spine surgery to work, people's problems need to be coming from their spine. That's a simple way of thinking about it. Now, you can't always tell that it's coming from their spine, but that's important rule number 1. Rule number 2 is people need to have identifiable structural causes for their symptoms. In other words, you have to know what you're trying to accomplish with surgery. You have to be able to say like, there is that disc herniation or that instability or that spinal cord compression. That's what I'm trying to take away. And I believe that problem is causing their symptoms. That you have to believe. So number 2 is people have to have identifiable structural causes for your symptoms that act as the guide for what you're trying to accomplish with surgery if surgery becomes the path of choice. Number 3, surgeons have to believe that they can fix that structural problem. There are situations where you say like, yes, people have that large disc herniation and it's causing their symptoms, but the treatment is worse than the symptoms they have, for example, or that person can't tolerate surgery. You have to believe that if you were to that, number 1, that you can go put the patient through something that allows you to fix that structural problem. And then lastly, you have to believe that you can go in and fix it and that is going to give them relief. Sometimes people can have permanent nerve damage where you go in and take the pressure off the nerve but don't expect the symptoms to get any better. And that's not really that effective in my mind. I wouldn't say surgery worked in that situation because patients likely have the expectation that their symptoms are going to get better. So number 4, you have to believe that fixing that structural problem is going to relieve their clinical symptoms. So just to reiterate, we're going to talk primarily about numbers 1 and number 2 when doing the clinical evaluation, but later we'll talk a little bit more about surgical decision making, figuring out what your goals are and figuring out how likely those goals are to really give people relief of their symptoms. So patients have to have problems coming from their spine. They need to have an identifiable structural cause for those symptoms. You have to believe, or the surgeon has to believe, that they can fix that structural problem. And then lastly, you have to believe that fixing that structural problem is going to give people symptomatic relief. Those are, in my mind, 4 important rules for making sure surgery is going to work, or at least increasing its chances of working. Now, cervical spondylosis, as we've said before, really involves age-related degeneration. In this picture, you can see that the spinal cord is under pressure. This patient may have cervical myelopathy. Cervical radiculopathy, in this case, this person has a disc herniation over here, causing pressure on the nerve, can cause a symptom pattern of cervical radiculopathy. And then neck pain, of course, may come from a lot of different things, but certainly could come from the arthritis in the neck, the disc degeneration, the osteophytes in the front, could come from muscular things or things like that can cause neck pain as well. But those are the symptom patterns, to reiterate, that we see with cervical spondylosis. We think about those patterns in a very structured way when we're getting our history, when we're doing our physical examination, and when we're looking at the imaging. When we're trying to put that all together, we think about those symptoms first of all, we organize them into symptom patterns. Then we look for concordance between the history and the physical exam. Then we try to correlate the symptoms and the exam findings with the structural and the imaging findings. And then lastly, on occasion, sometimes frequently, we'll look at confirmatory tests to verify either response to injections or EMG nerve conduction study. And the goal with all of that is to say, yes, we've arrived as confidently as we can at a cause for the symptoms that this person has. And that's a precursor for figuring out what the right treatments are. Now, there are a few important considerations with this. Number one, not all structural findings cause symptoms. And we see this a lot when people come in with imaging findings, for example, on the left with symptoms on the left, but they also can have pressure on the nerve on the right and no symptoms on the right. We see that all the time. But we go into it knowing that just because somebody has a problem on their MRI doesn't mean that that's what's causing their symptoms. Number two, often people can have symptoms that are not coming from the cervical spine, and that's important to recognize as well. There are a lot of things that can cause pain into the neck, cause pain and symptoms into the arms, numbness, things like that. So thinking broadly, having a broad differential diagnosis, being sensitive to like doing a detailed exam that may point to the shoulder or some peripheral nerve problem or thoracic outlet syndrome or something else, all of that I think is important. Important to recognize not all symptoms have to be coming from the cervical spine. Not all tests are perfect. Sometimes people's symptoms don't read the book, that their nerve, their C6 radiculopathy may be different from the classic kind of C6 radiculopathy. Sometimes in exam, the reflexes will be preserved at brachyradialis where you would expect it not to be. Sometimes they'll have like an EMG finding that says this C7 nerve is misbehaving, but it's actually C6 from the clinical picture and stuff. Putting all this together requires a little bit of tolerance for the fact that all of these tests are a little bit imperfect or may be imperfect. Number four, surgeons may not be able to address all symptom patterns. I mean, frequently we'll go into surgery for a patient with, say, myelopathy and radiculopathy, but have to establish that, like, listen, we don't know if the neck pain is going to get better. It may, or it may not, but we're really there to address the symptoms going into the arm and address the balance dysfunction and the clumsiness. It helps to go into surgery with a clear understanding of goals, and it helps to go in for the patient with a clear sense of expectations. And then lastly, some neurological symptoms are just not reversible. People can have permanent nerve damage. And so there are situations where you can see a structural abnormality, but people's symptoms have been so long-standing or multifactorial that you don't have conviction they're really going to get better with surgery. So fixing something structural may not actually serve the patient best. But those are kind of important considerations when we're thinking about cervical spondylosis and the clinical evaluation. We will talk next about decision-making in it and coming to different strategies for managing people both surgically and non-surgically. But I hope that during the course of this chapter, you've helped understand all of the different components for clinical evaluation for patients with cervical spondylosis. So in this chapter, we really discussed the clinical evaluation of people with cervical spondylosis. We started by talking about the framework that I use when I'm thinking about spondylosis. So we talked about cervical myelopathy, cervical radiculopathy, and neck pain, the three different symptom patterns that I think about with every patient with cervical spondylosis. I use that same framework when I think about history and obtaining a good clinical history, physical examination, and how to perform all the elements of it. We talked a little bit about the review of imaging and the relevance of it in trying to figure out where people's symptoms are coming from. And then we talked about the confirmatory studies, the EMG nerve conduction study, what that involves and the utility it plays. And then injections, and we talked a little bit about how those can be therapeutic and really diagnostic. I use them very frequently to help verify that people's symptoms are in fact coming from the cervical spine and maybe even specific levels in their cervical spine. And then we talked about how we could use all of that information and to synthesize it. So we have one diagnosis with some degree of confidence about where people's symptoms are coming from. Once you have a sense of where people's symptoms are coming from and feel confident in that, it helps you develop a meaningful management plan, which is the next step. That's what we're going to talk about next, is talking about what kind of non-surgical and surgical options people have. So up next, we'll talk about the management of cervical spondylosis. We'll talk about non-surgical management options, including physical therapy, injections, and other modalities. We'll talk about surgical decision-making, and this is going to be important. Again, until you understand where people's symptoms are coming from, it's hard to know where you're trying to get from a surgical standpoint. But surgical decision-making is a very important topic that we'll cover next. And then finally, we'll get into a more broad set of videos that get into the specific surgical procedures, whether anterior or posterior procedures. But all of that is coming up, and all of it is dependent on having a very good understanding of where people's symptoms are coming from. That is what I hope you've accomplished from watching this video, and I look forward to seeing you in videos coming soon.